Institute, and welcome to our online Seminars in Aging program today. I'd like to begin by acknowledging the traditional owners of the land on which each of us are meeting today. For me, that is the Girai Wurrung people of the Eastern Maar Nations. I'd also like to acknowledge the traditional owners of the lands and waters across Australia. I pay my respects to elders past and present, and to all Aboriginal and Torres Strait Islander peoples, including members of the Stolen Generations. First, a bit of housekeeping regarding Zoom. At the conclusion of the talk, we'll have some time for Q&A. If you do have any questions, please submit them through the chat function. You can find that at the bottom of your Zoom window, the two little speech bubbles icon. Today's seminar will be recorded and uploaded to the NARI website over the next few days. So keep in mind that if you turn on your video or you turn on your microphone and speak, then your voice or your image may appear on that recording. So today we're hearing from Professor Simon Bell, who's the Director of the Centre for Medicine Use and Safety at Monash University. He's also Adjunct Professor of Geriatric Pharmacotherapy in the Faculty of Health Sciences at the University of Eastern Finland. His research interests primarily relate to medicine use among older people, particularly psychotropic and analgesic medicines. He's produced more than 340 articles in scientific journals and been an investigator on over $45 million of research grant funding. He was a chief investigator of the NHMRC Cognitive Decline Partnership Centre and the NHMRC Centre of Research Excellence in Frailty and Healthy Ageing. And he is clinical chair of Australia's new clinical practice guidelines for the appropriate use of psychotropic medications in people living with dementia and in residential aged care. Today, he'll be presenting on research and practice related to medication safety in Australian aged care facilities. So welcome, Simon, and I'll hand it over to you.
Thank you very much, Andrew, and thanks to yourself and Jess and the NARI team for the opportunity to speak today. So I will talk about the topic of medication safety in residential aged care with a focus on some of the projects that we're currently conducting through Monash University, and look forward to comments and discussion that people may have at the end of the presentation. I'd also like to start by acknowledging the traditional owners of the land on which we're meeting. So Monash University's mainland campuses in Australia are based on the unceded lands of the people of the Kulin Nations, and I pay my respect to their elders past and present. And we're obviously meeting via Zoom today, so I also pay my respect to the elders past and present from where you may be joining us today. So medication safety is both an Australian and an international health priority. So back in 2017 rather, the World Health Organization declared medication safety as its third global patient safety challenge, and they had the objective to reduce severe preventable medication-related harm by 50%. In Australia, in 2019, the then Health Minister Greg Hunt declared that medicine safety would become Australia's 10th national health priority area, and that was really in recognition of the fact that medication-related problems cost the Australian healthcare system a lot of money, and there's also obviously a humanistic and clinical cost associated with that as well. So it's been estimated there's about 250,000 medication-related hospitalisations each year in Australia. And what we know is that older people are particularly susceptible to medication-related harm. But I think what we should see as both a challenge and an opportunity is that it's been estimated that about 2/3 of those medication-related hospitalisations could be potentially preventable. And older people often have high rates of preventable hospitalisations. The Pharmaceutical Society of Australia, which is the peak professional body for pharmacists in Australia, they produced a series of reports, including a report on medicine safety in aged care. And a lot of the advocacy work that's been done around the National Health Priority has been linked to these reports and the data that have been presented in these reports. So if we look specifically to residential aged care, data from our residential medication management review program. So this is where pharmacists review medications upon referral of a general medical practitioner. That data suggests that of those residents that are referred for review, about 95% have one or more medication-related problems identified by the pharmacist. And on average, this is roughly 3 to 4 medication-related problems per resident. Medication administration and medication errors and challenges associated with medication management are also a concern to consumers and carers. So medication management is one of the leading reasons to complain to the Aged Care Complaints Commissioner in Australia. And we often see medication-related incidents that have been recorded and reported as part of the reporting incident reporting systems within residential aged care. You can see on the left-hand side of the slide there the rates of psychotropic medication use both prior to admission, then at the point of admission, which is that dotted line, and then following admission to residential aged care. So it's been estimated that in Australia, about 38% of residents are dispensed an antidepressant medication, about 30 or 31% of benzodiazepine, and 21% an antipsychotic within 3 months of admission. And while psychotropic medications, of course, aren't always inappropriate, there are some appropriate indications for those medications. We often know that they're continued for long periods of time and are associated with different adverse events. And so the concern around psychotropic prescribing is often cited in those complaints, and it's been featured as part of the recommendations of the Royal Commission into Aged Care Quality and Safety. So the interim report of the Royal Commission into Aged Care Safety, they identified, or the report identified 3 areas needing immediate action. And the second area that was identified was the need to respond to the significant over-reliance on chemical restraint. So when we talk about chemical restraint in aged care, we often talk about the use of psychotropic medications. And so medications such as the antipsychotic medications and the benzodiazepine medications are often the most implicated in chemical restraint. Lots of medications, of course, have the sedative properties, and that's not limited to the antipsychotics and benzodiazepines. And so we often need to consider the sedative load, which is the cumulative effect of taking multiple medications with sedative properties. The Royal Commission made a number of recommendations, and a number of actions have flowed from those recommendations. And one of those recommendations was to develop a new clinical practice guideline for the appropriate use of psychotropic medications, and I'll talk in part about the development of that new guideline. Before I do that, I think it's worth considering the kinds of services that we have available to optimise medication safety in residential care. And one of those has been what's called the Residential Medication Management Review Program. Australia was one of the first countries to have a medication review program in aged care facilities. So the program was actually first funded through what was called the Second Community Pharmacy Agreement back in 1995. And pharmacists have been conducting medication reviews in aged care facilities since 1997. There has been a sort of gradual increase over time, but there's been a number of regulatory changes to the way that program is implemented. And so back in, for example, 2014, there was limits where the number of times that residents could receive that service. So it went from 1 year to every 2 years. And this is generally provided by a pharmacist who visits the aged care facility as a consultant. They're not typically directly employed as a member of the aged care facility. And so there's been some discussion around how we provide pharmacy services to optimise medication management in the residential care setting. This is some work that's been conducted by Janet Stuckert at the University of South Australia, and it charts the rate of the residential medication management reviews over time. And this is based on GP claims for that service. But we find, depending on the study, that only about 20% of residents receive a medication management review within 3 months of admission to residential aged care. More recently, the government has made funding available for aged care facilities to directly employ pharmacists. And so this program, called the Aged Care Embedded On-Site Pharmacist Model, was launched in July this year. There were some delays, but the model is up and running. And this makes funding available for pharmacists to become members of aged care teams and to work directly on site within those aged care facilities. And so while the previous service that I talked about, the Residential Medication Management Review, is a resident-focused service provided on referral of a GP, the aged care on-site pharmacist model allows pharmacists to be embedded as part of aged care teams to deliver both resident-focused and systems-level services. And so this is really one of the first opportunities that pharmacists have had to think about the clinical governance activities within aged care and contribute to a range of other sort of medication safety programs that perhaps they haven't been contributing to as actively as they might have in the past. So funding was initially announced for 4 years of this particular program. And so within the pharmacy profession, there's been quite a focus on how we train pharmacists to take on these new roles. And so there's a number of different providers across Australia have either launched or are actively working to launch training programs for pharmacists. And certainly anecdotally, within Monash University, our students are very enthusiastic to take on these new roles. So these are the different areas, 5 key areas of the aged care on-site pharmacist model that's been outlined by the Australian Pharmacy Council through a consultation process. And what you can see is that these areas extend beyond just that resident review of medications, but they also encompass activities such as clinical governance, person-centred care, the interprofessional communication and collaboration that is so important. And we know that prescribing culture within aged care facilities is quite a large determinant of the pattern of medication use within those facilities. And so these are other aspects are both a challenge and opportunity for the pharmacy profession to contribute to medication safety in residential care. And these are sort of the key domains that have been built into the training programs for pharmacists to work in this setting. So that's by way of background, and what I would like to do now is to talk about some of the projects that we've been working on at Monash University as they relate to those new developments within medication safety and the way that pharmacy services are provided to residential aged care. So I'll first of all talk about the clinical practice guidelines for the appropriate use of psychotropic medications, and also the new Australian dementia guidelines that we've been working on. And then I'll talk about 2 MRFF funded projects. So one is the Embrace project, which is a project looking to implement the new clinical practice guidelines for appropriate psychotropic use, and the MEGAMAC project, which is about implementing the department's new guiding principles for medication management in residential aged care. And if I have some time at the end, I'll talk about the Simpler project, which is an earlier project where we look to simplify complex medication regimens for residents of aged care facilities. So the tender was released following the Royal Commission to develop new clinical practice guidelines for the appropriate use of psychotropics. And Monash University was we were fortunate to put together the successful team to develop those guidelines. And those guidelines have been developed according to the grade process, and they've now been approved by our National Health and Medical Research Council. And subsequent to that, we've also received the tender to develop the new Australian Dementia Guidelines, which is a project between Monash University and Peninsula Health. And I'll talk a bit about this guideline development process. So ensuring that we've got up-to-date evidence-based guidelines, of course, is a really important part of ensuring medication safety. This is particularly important, I think, in residential aged care, because we know that residents of aged care facilities are often excluded from participating in clinical studies. In fact, it's been estimated that only about 2% of research in older people is conducted in the residential aged care setting. And so we often find that there's an evidence gap in relation to, or evidence practice gaps also in relation to the way we use medications in residential aged care. And we know residents of aged care facilities are often older and frailer, and therefore they may be more susceptible to medication-related harm than robust people who live independently in the community. But they also, therefore they're likely to have a different benefit to risk ratio for prescribing of medications. So the need to have clear guidance in relation to prescribing in aged care, I think, is particularly important. So we were commissioned to produce, there were 4 parts to this tender. So first of all, the clinical practice guideline itself, and that's designed for senior clinical staff, such as GPs and registered nurses, but importantly, also a range of other resources to support guideline implementation. And no guideline is going to be useful if it just sits on the shelf, of course. It's important that guidelines are implemented into practice. And so we use what's called an integrated knowledge translation process and that involved conducting an ongoing series of consultations with aged care providers throughout the guideline development process. And that helped inform the resources for other healthcare staff. So that included a series of fact sheets and also an inventory of existing quality use of medicines resources. We also produced a companion guide and the implementation and dissemination plan. So the guideline development process took part, or was conducted by an 18-member multidisciplinary team. And so that included both experts in evidence, so from Cochrane Australia, as well as a variety of different health and care professionals, such as geriatricians and clinical pharmacologists and psychiatrists. But we also had experts in knowledge translation and Indigenous and migrant health. We had representatives from aged care provider organisations, a GP, a legal practitioner, a physiotherapist, and consumers and carers. And you can see the structure of the guideline development team there. So we had a big focus on both translation, but also understanding some of the considerations for vulnerable groups. And certainly people with dementia and people, for example, from culturally and linguistically diverse backgrounds are examples of vulnerable groups that may be susceptible to medication-related harm. So the final guideline includes 15 conditional recommendations and 49 good practice statements. And the focus of the guideline is on antipsychotics, benzodiazepines and antidepressants. But the guideline also includes a series of general principles, and they relate to the use of all psychotropic medications. The guideline, unlike some other guidelines, also includes a section on PRN antipsychotics and PRN benzodiazepines, so PRN being as needed or when required medications. And we also address interventions that may be useful to optimise the use of psychotropic medications. The guideline includes conditional rather than strong recommendations, and that's because our consultation throughout the guideline development process suggested that even when presented with the same evidence, then consumers and carers would make different decisions in relation to use or not use particular psychotropic medications. And so that, I think, really highlights the importance of a shared decision-making process when considering psychotropic medication use. The 49 good practice statements, they represent according to the opinion of the Guideline Development Group, current best practice, and they're related to the evidence, but a lot of the evidence that we consider was indirect evidence, and so we formulated good practice statements rather than conditional recommendations in those cases. So it's beyond the scope of the webinar today, of course, to consider all of those recommendations of good practice statements, but just to highlight some of them. So these relate to antipsychotics specifically. So we've recommended against first-generation antipsychotics, and we've recommended against the routine use of second-generation antipsychotics. If an antipsychotic is prescribed, of course, then it should only be prescribed after non-pharmacological treatments have been trialled and found to be ineffective. And also the non-pharmacological approaches should continue alongside psychotropic medication. So it's not psychotropic or non-pharmacological. And antipsychotics should be reserved for distressing psychotic symptoms and or agitation or aggression that represents a direct threat to the resident or others. Documentation, of course, is really important, and that includes informed consent. Having specific target symptoms we thought was particularly important, and anticipated treatment outcomes, and also documented date of next review. We've also made a series of recommendations around the duration of treatment. So initial treatment shouldn't exceed 12 weeks. And after that, there should be a review by a psychiatrist or geriatrician or two medical practitioners where those medical practitioners agree with each other. We've done some recent work at the university looking at the proportion of people who initiate antipsychotics for change behaviours in dementia, and found that roughly half continue beyond that 12-week period. So thinking ahead, I think we need to be putting in place strategies to encourage review of antipsychotic medication beyond that 12-week mark. And I should also say that the full guideline is available on Magic App and also on our Centre for Medicine Use and Safety website. So I mentioned some of the education and dissemination activities. So to accompany the guideline, we've produced a series of one-page fact sheets. So there's 3 fact sheets each on antipsychotics, benzodiazepines, and antidepressants. And those fact sheets relate to the initiation, monitoring, and discontinuation of those medications. And you can see examples on the slides there of those fact sheets. We produced the companion guide. And so that's a guide available for people living with dementia and their carers. And we've had the companion guide translated into 5 languages. So that's both traditional and simplified Mandarin, Vietnamese, Greek, and Italian. And these are also available on Magic App, and you can see the website link there, or on our Centre for Medicine Use and Safety website. Another key feature of the guideline was good practice statements related to routine monitoring for adverse events. And we know that people living with dementia may be less likely to self-report adverse events to medications than people without dementia. And in older people, adverse events to medications are often missed. They're often overlooked, and sometimes they may be mistakenly attributed to the aging process itself. And so we've certainly advocated for routine adverse event monitoring. And one of our PhD candidates at the Centre for Medicine Use and Safety, Bridget McInerney, has developed a 10-item checklist for routine monitoring of adverse events. So these are monitoring of signs and symptoms that might suggest adverse events. And we conducted an international Delphi process to prioritise the top 10 signs and symptoms to monitor for people who use psychotropic medications. And you can see the list of those top 10 signs and symptoms there. On the right-hand side of the slide is an example of that monitoring checklist. And that's also available through Magic App and our Centre for Medicine Use and Safety website. So we're certainly interested to connect to people who might be interested in using that checklist, and we would be grateful for any feedback that people have in relation to that. So the guidelines were, the final version of the guideline was approved by NHMRC in April 2023, and that's certainly available for people to use at the moment. Most recently, we've been working on updating Australia's dementia guidelines. And so some people may know that the current Australian dementia guidelines date back to 2016, and these were developed through the Cognitive Decline Partnership Centre. And so the new Australian dementia guidelines are due to be released in 2026. And there's an updating process underway. And Monash University is working to update those guidelines. You can read more about the update on the website that I have placed there. And if you go to that website, you can also register your interest to receive updates about the guideline development process. And so I would certainly encourage those of you that are interested to learn more about that guideline development process to register for those updates. I just wanted to sort of use the opportunity to provide a brief update about where we're up to with the new Australian dementia guidelines. So what we've done is we've collated clinical questions from both the 2016 Australian dementia guidelines and also recent international dementia guidelines. So the guidelines that we've been looking specifically to are the NICE guideline from 2018, the SIGN guideline from the end of 2022, and also the recent Italian guideline that's been published this year. What we've done is we've matched the clinical questions across each of those guidelines, and then we've done a survey the survey has gone to our guideline development group, our advisory group, and then also a range of external stakeholders. And they've been invited to comment on each of those clinical questions. We've grouped the 3 questions under 3 streams, and these three streams are the streams that we'll use to develop the new guideline. And those 3 streams are risk reduction, diagnosis and therapies, and post-diagnostic care. So, for example, risk reduction is an area that hasn't been comprehensively explored in the other international guidelines. So that will be a new focus for the Australian guideline. We're currently going through a shortlisting and priority ranking process for the clinical questions to include in the new guideline. And so that's deciding which of the 2016 clinical questions will be retained, and also which we will add from an international guideline, or which may be new clinical questions to add. And so we'll then be conducting the systematic literature reviews for those new clinical questions to inform the decision of the guideline development group. So it's not too late to tell us what you think. We've been really keen to get feedback from as many people as possible in relation to prioritising those clinical questions. And so for those of you that are interested, please feel free to complete our survey. The survey, I believe, will be open until the end of the month, and you'll have an opportunity to express what you think may be important in relation to each of these areas. At this point, we're thinking that we would be updating around about 15 clinical questions to include in the new guideline. And now we're really keen to reach out for people. We had a public consultation webinar a couple of weeks ago and had a really good response to the survey, but there's still a couple of weeks left to respond to that. So I mentioned when talking about the guideline that the real success of the guideline will be, of course, whether or not it is implemented into practice. And so we've been conducting 2 MRFF-funded projects looking at guideline implementation. And the first of those that I wanted to talk about was the EMBRACE trial. So the EMBRACE trial, it's a Helix counterbalanced randomized controlled trial. And you can see the study protocol on the right-hand side there. It's a trial that we're conducting in partnership with 4 different aged care provider organisations, 1 each based in Victoria, New South Wales, Queensland and Western Australia. And it's across 19 different aged care facilities operated by those 4 organisations. And what we're seeking to do is to implement the new clinical practice guidelines for the appropriate use of psychotropic medications. And the Helix counterbalance design, in fact, I have on the next slide here, the Helix counterbalance design involves running concurrently the different guideline implementation strategies, but for different context areas. And in this case, the context areas are the 3 different medication classes that were considered as part of the guideline. So we have 3 different implementation strategies and 3 different medication classes. And the 3 different strategies that we're trialling are what we've called an on-site knowledge broker pharmacist, and I'll explain a bit about that shortly. Then also quarterly education sessions by a visiting pharmacist. And these visiting education sessions really sort of mimic current best practice. So these are funded as part of the pharmacist quality use of medicines activities in residential aged care at the moment. And so this is a currently available service. And the 3rd implementation strategy is passive diffusion of the guideline materials. So that includes both the electronic and hard copy guidelines and the various different education resources that we produced, such as the companion guide, the fact sheet, the adverse event monitoring tools, and the curated inventory of existing resources. So we're really looking to understand how we can best implement a new clinical practice guideline in the residential aged care context. Now, the highest level intervention is what we've called the knowledge broker pharmacist. And as I mentioned earlier on, most pharmacy services in aged care at the moment have been focused on the resident, so those residential medication management reviews. But with the aged care on-site pharmacist model, we have an opportunity for pharmacists to undertake system-level sort of clinical governance roles. And that's been the focus of this highest level intervention that we're trialling for guideline implementation. So the knowledge brokers, a knowledge broker is somebody who acts as an intermediary to help move knowledge from those that make it, such as the guideline developers, through to those that use it, which in this case could be the aged care staff, healthcare professionals, and aged care provider organisations. And so it's really a flexible intervention designed to really take into account the context of each individual aged care facility and aged care provider. And the design of this knowledge broker intervention was based on the focus groups and interviews that we did throughout our guideline development process. So there are 3 different domains to knowledge brokers, and this is really drawing on the work of one of our research fellows, Dr. Amanda Cross, who has written a review on knowledge brokers for the purpose of translating clinical practice guidelines. And the 3 different domains are being a knowledge manager. So that's really creating and distributing guideline material within residential aged care and planning for that local implementation. Being a linkage agent, so that's really engaging the different stakeholders, both internal stakeholders within the aged care facilities, but also external stakeholders such as GPs, for example, and also working with other knowledge brokers. And we know that this sort of stakeholder communication is a really important determinant of medication use. And aged care facilities often have high turnovers of staff, and staffing is obviously an issue across all areas of the healthcare system at the moment. And so the opportunity to have a linkage agent to facilitate that sort of seamless communication and medication knowledge could be particularly important. And also about capacity building. So that's often about education of staff. It's about audit and feedback to actually drive change based on local data within each of the facilities, and really exploring what those local barriers and facilitators to change may be within residential care. So the intervention phase of that project was just finished in October this year, and we've been looking forward to seeing the results of that study fairly shortly. The second MRFF project that I want to talk about is what we've called MegaMAC. And the MegaMAC is about maximising the use of medication advisory committees. So each aged care facility in Australia is required to have access to a medication advisory committee. And a medication advisory committee, it's a multidisciplinary committee for clinical governance of medication management within the residential aged care facility. And it's recommended that each of these committees meet on a quarterly basis, and they really direct the policies and processes related to medication management. This is a system that doesn't exist necessarily in many other places around the world, so it's something that's relatively uniquely Australian, and I think it's a really good initiative. And there's been relatively little focus on medication advisory committees over the past sort of 20 years, even though they have existed. Some years ago, we did a consultation on behalf of the Victorian, what was then the Department of Health and Human Services. And this was based on looking at the role of medication advisory committees in public sector residential aged care facilities in Western Victoria. And what we found is that the composition and the structure of MACs was highly variable. So, for example, some were multidisciplinary, whereas some were predominantly nurse-led committees. Some involved external stakeholders, but others were more internally focused. What was interesting was that a lot of these medication advisory committees, they tended to act in isolation. So people sort of sat on one committee only. They didn't necessarily sit across multiple committees. And we felt that that represented a missed opportunity for sharing of innovative and best practice. So out of those MACs that we consulted with, there were some really good examples of innovative best practice and really quite exciting local solutions to improving the quality use of medicines. But those lessons learned weren't necessarily shared with other medication advisory committees. And as a whole, we felt that there was an opportunity to be more proactive in addressing quality use of medicines activities rather than being reactive. So medication advisory committees often, for example, consider the medication incidents over the previous quarter. And so instead of just retrospectively looking at those incidents, we felt there was an opportunity to proactively to devise strategies and interventions that would hopefully reduce those medication incidents in subsequent quarters. So it's really this thinking that really sort of fed into the design of the new project, which we've called MegaMac. And MegaMac, it's where we have what we call a knowledge broker dyad. And the dyad is an aged care on-site pharmacist and one other MAC representative at each of our participating 15 aged care facilities. And then those knowledge broker dyads are supported by what we call a National Quality Improvement Collaborative. And this has been based on some work that Kate Laver, who's one of the chief investigators on our project also, has done in terms of guideline implementation for the 2016 Australian Dementia Guidelines. And this National Quality Improvement Collaborative is really an opportunity to bring together representatives from the different medication advisory committees to share their learnings and to work with clinical experts and knowledge translation experts and also consumers and carers on different strategies to support local quality improvement. And this is a 9-month intervention. We've just started the intervention last month, and we're working with 3 different aged care provider organisations across Australia to implement this particular project. For both the Embrace project and the MegaMac project, we've been working with the New South Wales Therapeutic Advisory Group. The MegaMac project here is about implementing the new guiding principles for medication management in residential aged care that were published by the Department of Health at the end of 2022. And so you can see the different domains here. And these are indicators that can be used by aged care facilities to track concordance with the new guiding principles for medication management. And it's these indicators that will be informing the development and evaluation of the local quality improvement processes that will be developed at each of the aged care facilities and discussed with the Medication Advisory Committee, and then also the National Quality Improvement Collaborative. And you can see the different domains of indicators here and which of the guiding principles that they cover as part of this new guiding principles for medication management. So this particular slide shows the system where it's been developed by the New South Wales Therapeutic Advisory Group. It allows aged care facilities to measure concordance with the new guiding principles document and then track that concordance over time, and then to use that to develop and evaluate those local quality improvement activities based on local action plans. And so our knowledge broker dyads, the pharmacist and the member of the Medication Advisory Committee will be using these dashboards throughout the development of the project. So just in conclusion, aged care pharmacy it's quite an exciting area, I think, at the moment. There's been a lot of developments within and outside of the pharmacy profession related to medication safety in residential aged care. And I would argue it's become a third major area of pharmacy practice, sort of alongside community and hospital pharmacy. Certainly, I see that universities have a key role in innovation, working in collaboration with aged care providers and other stakeholders. Haven't spoken so much about medication regimen simplification today, but happy to discuss that as part of the comments or questions. And also the knowledge broker pharmacist role and medication advisory committees, I think, are key ways that we can help improve medication safety in the residential aged care setting. So with that, I would like to thank the many people and many funding sources that have contributed to this body of work. I'm really grateful to the great team that we have at the Centre for Medicine Use and Safety. Amanda, Amelia and Brooke are really doing an amazing work with the MegaMac project and the Embrace project, and I'm certainly very grateful to them and the wider team, and yeah, look forward to the comments and questions that people might have. So thank you.
Thank you very much, Simon, for that overview of quite a large program of work. So we do have time for some Q&A if anybody has any questions. If you do have a question, you can write it in the chat box and we can read it out. Otherwise, if you'd like to ask it in person, maybe just turn your camera on and wave at me or something, and then I'll call you in turn So do we have any questions? I just had a question. It's a fairly simple one. I'm just regarding these Macs. Where are they situated? Like sort of where in the health or aged care system are they based?
Sure. So there's different models that exist. So individual residential aged care facilities sometimes have their own MAC at that facility level. Sometimes aged care provider organisations will operate MACs at a regional level or at a provider level. And so one of the activities we did initially actually was to conduct a survey of medication advisory committees around Australia. And there's quite a variety of different models. So some MACs are quite focused. They're looking at quite small numbers of residents. Others are sort of cross-cutting MACs that actually work at that higher sort of regional level. And so I think there's probably not a lot of good consensus about what represents the perfect medication advisory committee. And so hopefully through the project, we'll be able to come up with some recommendations sort of further to optimise that. We did produce a series of recommendations back at our earlier consultation. And so some of those included things like having an independent chair, having a terms of reference for the medication advisory committee. We recommended there should be resident and carer involvement in those medication advisory committees, and they should be multidisciplinary. But there are a variety of different structures that exist. And I think hopefully through the project, we'll be able to generate some evidence in relation to what sort of represents current best practice in relation to those medication advisory committees.
Right, thank you. We have a question from Amy Parker. Do you have any comment on the use of ADHD medication in residential aged care?
I think it's certainly fair to say that I don't have a specific comment in relation to that, but what I would say is that there's quite a variety of different medications with psychotropic properties that are used in residential aged care. And the guidelines that we developed focus on antipsychotics, benzodiazepines, and antidepressants. But we've often been asked about a range of other psychotropic medications. That could include ADHD medications. It includes things like some of the anti-seizure medications that are used. Opioids are another medication class with psychotropic properties. And so I think one of the challenges is really generating a good evidence base for medications that are often used off-label in the residential aged care setting. And so I think what we need to be doing is looking to sort of routinely collected data and real-world evidence, given that there's a lack of randomised controlled trials in that setting. So I don't have some specific comments in relation to ADHD medications, but where medications are used off-label, I think we should be clear and transparent about that. And I think we need to be really developing a program where we can generate evidence that's specific to the residential care setting.
Right. I have a few comments and questions now about Macs. I'll just ask, I'll voice the first two. The first one's a comment and the second one's a question. The first one's from Kelly Healy, and she's saying she's aware of a Mac in her organization, but they don't feel they hear feedback or information from them. And then we have a question from Murray Vaughan. What percentage of residential aged care facilities conduct Macs, and what are the barriers to uptake?
Sure. So I think first of all, I would say that different aged care provider organisations have different structures in place. So some of the activities, such as sort of overseeing education and training related to medications in some aged care provider organisations, are managed by quality and safety teams or education teams. And so some of those roles may exist in other parts of the organisation. I think as I mentioned, the composition and structure and the role of those MACs varies considerably. I think we've had some questions about who should be represented on MACs, and certainly I think pharmacy and general practice are important sort of disciplines to have involved on those MACs. I think where pharmacy and general practice can be involved, there's often an opportunity for those sort of clinical discussions and that sort of more proactive clinical discussion. And I think that's a really important thing to facilitate. And I would certainly hope that would flow through the whole organisation, because sort of, as I mentioned in the presentation, organisational culture is such an important determinant of medication use within residential care. And it's really important, we know, to engage all the different health and care professionals within that organisation if we're going to bring about quality use of medicines. mean, the
And
example of psychotropic monitoring is really key with that. Often it's the care workers that have the most contact with residents and are perhaps ideally placed to recognise some of those signs and symptoms that might suggest adverse events.
I think you've addressed Melody's question. So Joan has her hand up. Joan, would you like to ask a question or comment?
Sure, thank you. Thank you, Simon. Fantastic work. I'm working actually with Amanda on trying to reduce anticholinergics in residential aged care projects in aged care homes. But my question is really going to the area of GPs and their role in all of this, but also the registered nurses in aged care, because clearly both groups are very important when it comes to the decision for a person to receive medication of any type. So I'm interested in, what your experience is in trying to firstly change GPs' prescribing behaviours, but secondly, recognising that registered nurses often are the ones that are receiving pressure from families and who perhaps might then pressure GPs into prescribing. I wonder if you'd like to comment on that.
Yeah, thanks. Thanks for the question, Joan. I think that medication management decisions are, as I think you've alluded to, influenced by a range of different factors, and that can include residents and carers, nurses, and GPs. I think that it's really important to have a shared decision-making process, and I think it's really important that all members of the healthcare team are really able to contribute to those discussions. Certainly, I think it's easy, I think, to sort of, we believe that somebody else is responsible for a decision, but I think all of those parties are really important. And I think from a GP perspective, I suspect it's easy not to prescribe if you feel that you've really got the support of that care team in terms of providing non-pharmacological management. But I wouldn't underestimate the challenge that many nurses and care workers have in that aged care setting. And so I think it's really where we have the whole team on board that we can make those best decisions. And often I think it's about having education. Hopefully the fact sheets that we've developed through the guideline process may be useful for facilitating some of those discussions. And that may include with residents and family members that may feel pressured to, or may apply pressure to prescribe or not prescribe specific medications. So hopefully those resources can be useful for all parts of the healthcare team. But I would say that, I fully agree that nurses and care workers have such an important role in facilitating those discussions, and they're there, they're speaking regularly with families. They're the ones who have those conversations about what to expect from medications, and also what side effects or what adverse effects people might want to look out for. So I think it's really a collective team effort, and I think all we can do, if we can, all the different strategies we can put in place to bring those care team members together are really important. Hopefully knowledge brokers may be one of those strategies, but I think there's probably other strategies as well.
Okay, is there anybody else who has a question? No, looks like we've finished. So please, everyone, let's join me and thank Simon. You can use your clap reactions. So next month we'll be having someone speak from the academic unit of psychiatry of old age. They'll be organising a speaker of their choice. So please join us next time, which will be on the 10th of December at 12 p.m. And that will be our last seminar of 2024. Thank you everyone for attending the Seminars in Aging series. Have a great day.